What's going on, guys? Today we're going to be looking at childhood disorders of the hip, and we're going to be focusing on some of the most common at various age groups within childhood, going from babies to toddlers to kind of kindergarten age to puberty and whatnot. And we're going to try to focus on the primary ones that will probably be tested, whether it be on the surgery shelf, step 1, step 2, whatnot, and then be able to distinguish a lot of these, because a lot of these can present very similarly. So I've focused on a lot of the high yield clinical points that you can find either during clinical exam or when you do some sort of observation into lab testing and imaging. I'm going to focus on the high yield points to help you to get which of these disorders it's going to be. So here's the list that we have. This is the primary list that we're going to focus on, starting with developmental dysplasia of the hip, then moving into Legg-Calvé-Perthes Disease and slipped capital femoral epiphysis. The reason I've color-coded these is because the ones that are color-coded, whether it be blue, red, or green, they're all, the ones that are clustered as the same color just means that they can present very similarly and may be kind of hard to differentiate between the two on a test. So that's the ones that I've chosen to explore more and kind of cluster together to help you differentiate, looking at some really high yield distinguishing factors. So Legg-Calvé-Perthes disease and slipped capital femoral epiphysis both can present very similarly in the clinic, along with septic hip, also known as septic arthritis, and transient synovitis of the hip. Those can also present similarly. So let's move right into this and start. The first one's going to be developmental dysplasia of the hip. So if you watch any of my videos, you know I always use little clever things, whether it be in the title of the disorder or a mnemonic that I developed that goes really well with it to help you to remember some of the key points to get the question right on the test. So developmental dysplasia of the hip, just break the word down. Developmental dysplasia just means like bad formation or bad production of something, a tissue or organ or whatever, and then of the hip. So this is telling you you're having during development, you had bad formation or development of the hip. So I use the word developmental first. I look at that first word, developmental, and that kind of reminds you that this is mainly detected in babies who are just developing. So that'll help you get the age group. The age group is going to be very important for all of these. The exams love to focus on what is going to be the most common presentation. So if you know the age group that this will primarily be detected in, then it'll help you to kind of guide you towards the correct disorder of these primary hip disorders. So the next thing is, like I've already explained, dysplasia basically just means bad development. So you have bad development of the hip during the developmental period. And I said that if you think of somebody who's just starting to go through development or developmental stages, that's going to be a baby. So that helps you remember, okay, who does this primarily present in or is detected in? It's detected in babies. And the dysplasia means bad development. So we have bad development of the hip. Bad development of the hip. Now, here's some important things. Because you have bad, now in a baby, they're not going to be able to tell you something's wrong with my hip. Of course, a baby, when you first detect this, they're not walking. So you have to have a clinical exam of the hip. So what you do, you lay the baby down and you basically have their hips kind of abducted outward. So they're hanging out on the exam table. And their hips, you start out with a flexed knee like this and then abducted hips. So you open their legs up and you abduct the hip. And then what you do is you adduct the hips back as you push backwards posteriorly. And when you do that, if you can dislocate the hip, you'll hear this little like a noise. It'll almost be like a click or something. And then when you hear that, that means that you've dislocated the baby's hip. Now this doesn't hurt the child. But this is an indication that it's a Barlow test positive. Barlow test positive. So Barlow, just think Barlow back. You push back as you're adducting the hip, you push back and then it makes that click noise. That is a Barlow test positive. That means you've just dislocated the hip. Now this doesn't hurt the child because at this point there's not much development in the hip. The hip is dysplastic and the baby hasn't developed fully and calcified the bone. So it doesn't hurt the child, but this is letting you know you've just dislocated the hip. Then what you do is you go back the opposite way, so you abduct back again, back this way, and you push back outwards and you can pop the hip back in. That's the Ortolani test positive. So these two tests are usually going to be positive in cases where a child would probably have developmental dysplasia of the hip. Another thing you can do, I don't remember the exact name for the test, but you can do this. You flex the child's knee again, and you abduct the hip, or I'm sorry, you don't abduct the hip, you actually adduct. Adduction. So you adduct, you bring them in, but you keep the knees flexed like this. And you look at the height of both of their knees. If one of the knee heights is lower than the other one, then that's kind of hinting towards that probably one of their hips are dislocated at that current moment. So when you go to do the Barlow-Ortolani test, you're probably going to get a positivity somewhere in there. And this is all stuff hinting towards developmental dysplasia of the hip in the clinical setting. Then also something you can look at is you can pick the baby up and turn it around and look at the gluteal folds of the baby, and if they're uneven, so if this is the baby, here's the gluteal fold, the fold is at the bottom of their butt right here. If that's uneven and one is down here and one's up here, that's going to be uneven gluteal folds. That's also hinting towards a possible dislocation of one of the hips, and that basically one of the hips is dislocated and you just didn't know it. So not only will these tests the Ortolani and Barlow give you a hint towards that, the uneven gluteal folds will also give you a hint. Now here's something really high-yo to know about this disorder, developmental dysplasia of the hip. You can't use, the x-ray is not the imaging modality of choice. The reason is because it's a baby, and babies don't have fully developed bones yet. They haven't fully calcified, so you have to use a sonogram to detect this. Okay, so that is developmental dysplasia of the hip. I have already showed you the way to remember a lot of this. Developmental should help you think, okay, we're dealing with somebody who's who's just starting to develop. That should hint you towards we're dealing with, this is probably in babies. That's going to be detected. Dysplasia, if you just know what that means, that just means bad development. And then it tells you of the hip, developmental dysplasia of the hip. So you know kind of what's going on. Then the rest is on you to remember uneven gluteal folds, what the Barlow and Ortolani tests are, and then that you really have to remember sonogram for imaging, not x-ray. Okay, so let's move into the next one, Legg-Calvé-Perthes disease. So this particular disease right here is going to be very similar to this one, slipped capital femoral epiphysis, but I'm going to show you, I've put in bullet points some of the differences to help determine between the two. So let's start with this one, Legg-Calvé-Perthes disease. All this is, I was confused because when I first started studying this, I thought that Legg-Calvé-Perthes disease was a completely different disorder than something like avascular necrosis of the femoral head, but that's not right. Actually, all this is a childhood avascular necrosis of the femoral head, but the reasoning is they think it's due to rapid growth of the bone. So if you remember, so first of all, you have to know, this one is not going to be detected in babies. This one is going to be detected in a child who is, like, you could say early school age or Lego toy age. So like Legos, like those little building blocks that you can put together. Think of about when you would be playing with those kind of toys. So you're thinking anywhere, 4 to 8, 4 to 9, something like that. I mean, you're going to see different sources will tell you different things, but just think that it's not going to be the pubertal age, right? It's not going to be the age of during puberty, and it's not going to be a baby. It's going to be kind of in between that, almost like that toddler to older, a little bit older than toddler age. So the age that you would want to be playing with Legos. Why am I telling you Legos? Because look at the title, Legg-Calvé-Perthes, Lego. It'll help you think of Lego. Okay? So that's a hint to remember if you have a child who's 6, 7, 8 years old, even 5, even 4 or 5 or something like that. That's going to kind of hint you towards this particular disease if they're having hip problems. I also want to go ahead and tell you a side point, and this kind of applies for all of these hip disorders. Children that have hip disorders can very often present with knee pain instead of hip pain. So they may come in saying that their knee is really hurting. You have to know, just as a clinician, that when a child comes in with really bad knee pain, say you would do tests on the knee, there's nothing wrong with their ligaments, there's no sort of developmental problem in their knee, you really need to be thinking also hip problems, because they can present with hip issues, and it'll basically be hidden in this knee pain instead of hip pain a lot of times. So they have something, this particular disease also. So we said this is avascular necrosis of the femoral head. What does that really mean? Well, I've already explained to you the hip. So let's just take this as a kid now. And here's the femoral head that's going into the hip right here, the little hip capsule. What you can have is you can have an avascular that means that the vascular supply, for whatever reason, you're not getting blood to the femoral head, and it begins to die off and necrose. And when it's necrose, macrophages can come in and eat the remaining debris of the left that's of the bone, and now you have less bone density. You basically lose the bone that's at the femoral head that's supposed to go into the hip, and you can have hip problems from that. Now, that's the same exact thing that happens in avascular necrosis of the hip in adults, except for the reasoning is different. In children, it's usually going to be because of this rapid growth of the bone. Think of a child who is, early school age. They're growing and they're getting bigger, and the growth plate is not closed, whereas in an adult, the growth plate is closed. So when you have this really rapid bone growth, the vascular supply, for whatever reason, doesn't grow as fast as the bone is growing, as the bone's growing. So therefore, you have a deficit of blood supply as the bone gets bigger, and they're thinking that is one of the proposed mechanisms for this disease, Legg-Calvé-Perthes disease. Okay. Next point. They have something called an antalgic gait. That just means that the hip that's affected, so when they're walking, the hip that's affected, when they put weight on that particular leg, say in this example, it's the left leg that's hurting. When they put weight on it, they will go through that step extremely fast and go back to the right. So for example, if they were to take this step forward, they'll do it extremely fast just to not put weight on it, and they'll hurry up and go back to the right. So the right leg is basically has a longer phase in the walking cycle than the left, the one that's hurt, the hip in the left. So that's called an antalgic gait. You'll see them hurry through the left, the one that's injured, that particular leg, they'll hurry through the walk of that, and they'll try to avoid the time that they have to put weight on that leg. That's called an antalgic gait, and that's common in Legg-Calvé-Perthes disease. Now I want to jump ahead and show you. Look in this one we're going to talk about later, slipped capital femoral epiphysis. Look here. Antalgic gait. So that also presents with antalgic gait. I'm going to show you something else. Issues with internal rotation abduction. So the child's not going to be able to bring their leg outwards, which is called abduction, AB. They're not going to be able to bring that particular leg where the hip is messed up. They're not going to be able to bring it outward, and they're going to have struggling with internal rotation, which is when you turn your leg or rotate your leg inward. They're not going to be able to do that, rotating the leg inward, but they can rotate it outward. So you're having issues with that, antalgic gait, and issues with internal rotation and abduction. But look, you have the same exact issues in both of these. And when we talk about slipped capital femoral epiphysis, you can't do either of these as well. You can also see these symptoms. And that's why it's important to know some of the other defining characteristics, especially knowing what is actually happening in the disease. That'll help you guide in each of the examples to differentiate what the answer is. A really important defining characteristic that is in this one predominantly and not the other one is thigh and calf muscle atrophy. Now this is the way I think about that. The real reason this happens is because you're not using the leg. Because the leg is having a vascular necrosis of the femoral head, you have this antalgic gait that I talked about up here. And when you have that, of course, you're not using the muscle as much as you should, so the muscles break down in your legs, in the thigh and calf. So they atrophy. But you should also remember in slipped capital femoral epiphysis, you're going to have something similar. They're not going to want to use the leg that's messed up. And so you would think it would be presenting in this one as well. So the way to remember this is that in this particular example, you see how in the title, let's go back up to the title, I love mnemonics, Legg-Calvé-Perthes disease. Look here, Calvé, or however you pronounce that, it looks a lot like calf, and that helps me to remember, oh yeah, so this is the one dealing with muscle atrophy predominantly. Now I'm not saying this is a concrete rule, like you can't have any muscle atrophy in the other one, the slipped capital femoral epiphysis. You can, but predominantly it's going to present in this one. So that helps me to remember when I see that legg-calve, calve, so that helps me remember we can have thigh and calf muscle atrophy in this particular disease, and that should be a really good defining characteristic to think that the patient has this disease instead of the slipped capital femoral epiphysis. That's the first defining point. The next one is if you were to get x-rays of this child who's in this age group of about 6, 7, 8, somewhere around there, you're going to see lucency of the femoral head on x-ray. Now I'm going to show you, what does that mean? That just means the femoral head, remember I said it's avascular necrosis, so it's broken down. So what does that mean? On an x-ray, let's go to, here's the x-ray. Let's look at this. You see how over here on this side, there's the head, the femoral head that's going into the capsule, and then you see here there's nothing there? Because remember, on an x-ray, the black just means this air. There's nothing there, basically. All the white is the bone. The black is just empty space. It's just air and tissue and stuff that the x-ray, picks up as just black area. So that shows you're just missing the femoral head. Well, that should be easy to recognize on an x-ray, because on this particular one, you have no femoral head. But when we get to this example, slipped capital femoral epiphysis, you have a femoral head. It's just a little bit off a line. So that's an easy distinguishing factor. When they give you an x-ray and you're literally missing the femoral head of the femur that is supposed to be going into the hip at the capsule, that should help you remember, oh, this patient probably has this Legg-Calvé-Perthes disease, especially if they're a child. Now, if they're an adult, it would just be called a vascular necrosis of the femoral head. And we've gone through the differences between that. So they're going to have a lucency of the femoral head on x-ray. And then what do you do for this? Well, in this particular example, surgery, it's usually less likely, because the reasoning is when a child has this, usually if they just kind of take it easy on the leg, the vascular supply can catch up, and eventually you'll have angiogenesis, and then you'll have a bigger blood supply that should fix the problem. But you want to monitor closely, because there is situations where the child doesn't get better, and then you are going to need a surgery to fix this. But this is the one where you're more or less, you just need to begin to monitor over the next one we're going to talk about, which is usually almost always you're going to need some sort of surgery. So here's the next one, slipped capital femoral epiphysis. Let's just look, and again, I always tell you, just look at the title of the disorder. Something has slipped. What has slipped? The capital femoral epiphysis. It's telling you exactly what's happening in this disorder. So in this disorder, you have your femur, and then you have, like the head part that goes into the hip capsule. All that's happening here is there's a growth plate right here that is kind of in between the epiphysis and the metaphysis. It's kind of like sitting almost kind of around that in that area, and then this is the diaphysis over here, so just basic, long bone anatomy. So there's a growth plate in here that's called the growth plate, or it's also called the physis. This particular part, for whatever reason, it almost disconnects these two pieces, and you have the femoral head slides downward, and this piece right here, when the femoral head breaks up off from it at the physis area, this shoots backwards because it has nothing then to support it into the hip capsule. So this part goes backwards posteriorly, kind of infraposteriorly, and then the femoral head, it slides downwards, and you're going to see what that's going to look like on an x-ray, because it's funny how they describe this. So let's look at the description. When the femoral epiphysis actually slides off of the femoral neck, which is what I just explained. The epiphysis is like where the femoral head is. And so who's going to get this? It's going to be kids that are now in the age of puberty. So now we're looking at the 10, 11, 12, 13, that kind of age. It's a little bit older than the previous example. In the previous example, Legg-Calvé-Perthes disease, I said it's about 6, 7, 8. So how do we remember that? Because when you look at this part, leg, remember Legos, and younger kids would usually want to play. You rarely see a kid who's hitting puberty and is heading in high school, or is a freshman in high school, playing with Legos. That would be more of an age group 6, 7, 8 years old. In this example, this is a little bit older kids. So this is when the femoral epiphysis actually slides off the femoral neck, and this is going to be in an age, the kid's age is going to be at puberty, and they're usually chubby. So usually it's going to be a kid who's a little chubby, who's undergoing some type of activity, and then they always seem to limp afterward. Okay, and how do I remember this particular age group for this disease? So I just think of, when I see the word slipped, I just imagine that chubbier people may be more prone to slipping. Okay, they may be a little less balanced and a little less agile than kids who are skinnier and maybe more in shape. So that's just something that I use to remember that now for this age group, the slipped capital femoral epiphysis, I think anybody who's the person more likely to slip, it's going to be a chubby person. Okay? And the age group for this is 10, remember I said 10, 11, 12, 13, somewhere in there, basically the age of puberty. Now remember what I told you earlier. There's the antalgic gait. That's the gait where, whatever side hip is affected, they don't want to, that walking phase of that, when they take a step with that foot and go to put weight on their leg, they're going to fly through the motion because it hurts when they put pressure on the leg. So they're trying to not bear weight on it, and so they shoot their weight to the other side as fast as they can. That's called the antalgic gait. And then again, there it is again, issues with internal rotation, abduction. Naturally, if you have, say this is the head of the femur, and it literally rips right off and slides down, you have no connection any longer into the hip. So you're not going to be able to, so when this shoots backwards posteriorly, you end up with issues with internal rotation and abduction. Okay? And that should intuitively make sense because you need the hip to abduct, you need the hip to internally rotate. All right. And then what is X-ray going to show? It's going to show there's actually a number of signs, 4 or 5 signs, but I've picked the 2 signs that I think are the most easy to see. And the other sign I'm going to show you is kind of a generalized sign that you can see on almost all X-rays. So the first one I'll talk about is the X-ray can show something called, and it's literally, this is crazy, it's literally called this, like practitioners know it by this name, ice cream falling off the cone. This is a sign on X-ray called ice cream falling off the cone. What does that look like? When we go here, do you see, here's the femoral head. The femoral head has literally, it's not necessarily that the femoral head has slid down per se. It's really the fact that this thing has is slid there at the physis. It has slid upwards and has gone kind of backwards posteriorly. So it looks as if this has slid down. So when you remove all that, what you see is, do you notice how if this was the cone, and this is the top of the ice cream, do you see how the ice cream part of the cone that I just drew, it looks like it's sliding off of the cone? That's called and that's literally the name they gave it, ice cream falling off of the cone sign on X-ray. This is fairly diagnostic for a slipped capital femoral epiphysis. Another thing it can have is something called a metaphysis steel sign. All that really means, and it's not like I said, these 2 signs are not present on every single X-ray. You can just look for these 2 signs. So I don't have an actual X-ray of this one, but what you would see if it was here is that when this particular femoral head begins to slide off like it does, and this piece right here goes backwards, sometimes when this particular piece goes backwards, this the bottom piece connected to the femoral head, when that top piece slides off and it shoots backwards, it can sometimes go up behind the femoral head. So here's the femoral head. This whole shaft piece can sometimes go behind, and you'll have an area that looks almost like a crescent. It'll be a little darker white than normal. That's called a metaphysis steel sign, and all that's hinting towards is that some part of this shaft piece has gone up behind the femoral head, and so you'll see an area of darker opacity on an X-ray, and it'll be crescent shaped almost. You'll see a darker area. That's called the metaphysis steel sign. Okay, so that's slipped capital femoral epiphysis. And then the last 2 we're going to talk about. Now, typically, I've seen in sources, septic hip is kind of just talked about alone, but I want to talk about transient synovitis of the hip with it, and I'm going to explain to you why. So to start, septic hip, by the way, this will confuse you too, and it took me reading a lot of sources to finally see and understand that septic hip, another word for that is just septic arthritis. Okay, so when you see septic arthritis in a lot of sources, it's referring to septic hip. So, septic hip in a child is exactly what it sounds like. It's a bacterial infection within the hip, okay? And it is non-sterile. What does that mean? Something that's non-sterile means that there is bacteria and pathogens and whatnot located where the infection is, which would be in the hip capsule, okay? So the effusion, what that means is if you were to tap the hip and get some of the fluid out, the effusion out of the hip, it's going to have bacteria and junk and pathogens and all that in it. So it's non-sterile. This is called septic hip. Now, who gets this? This is usually in children around 3, 4, 5 years old after a post-febrile infection. So this can be a numerous number of infections can cause this, but usually they're going to have a fever, and then a week or 2 or however long afterwards, all of a sudden the child is refusing to move the hip and they won't bear weight on it and it's painful. That's septic hip. Now I'm going to show you, as I was studying, I remembered another disease, transient synovitis of the hip. Let me look at how similar this is. This is also in children. Usually the age is a little bit older, but it can also be in the same age as septic hip. The ages overlap a little bit. This is in a child who has a post-viral infection. And after the post-viral infection, they get an inflammation of their hip capsule in the hip. Now, see, it sounds all kind of similar already. But they're also gonna have an effusion, but the effusion is sterile. But you wouldn't know it was sterile unless you tapped their hip and tested the effusion of the hip. So in a clinical setting, these patients can present extremely similar. They refuse to move the hip, they won't bear weight, and it's painful. That can all be present as a possibility. How do you distinguish the two? Well, I'm going to show you a couple points that I usually use. In most cases of transient synovitis of the hip, it's post-viral. Whereas up here, it's usually from bacterial infections that you would have a febrile infection. This is kind of more specific to viral infections, so it's going to be post-viral. The next thing is that if you were to just tap the hip, you couldn't figure out what particular disease it was, then you end up tapping the hip and you realize this is a sterile effusion. There's no bacteria, there's no pathogens in the fluid, it's just inflammatory material. That is going to then be hinting you towards transient synovitis of the hip over septic hip. But these symptoms, refuse to move the hip, won't bear weight, painful, all that stuff, an infection post, all of a sudden their hip is messed up post some sort of infection, that's not going to help you distinguish. So a criteria was developed by a doctor to distinguish, even on top of the things I've already said, on top of the fact that it's a sterile effusion, on top of the fact that it's usually post-viral. If that's not enough to distinguish, which majority of time it isn't in a clinical setting, here's the criteria you use. There are 4 points that you look at when you know something's wrong with the hip and it's probably one of these two things. You use these 4 things. You look at the ESR. Remember, that's just the sedimentation rate. You can also look at the CRP as well. Both of them are inflammatory markers. But this particular criteria, it uses ESR, so I would use ESR here. It looks at temperature. It looks at the fact of will you bear weight at all on it in any sort of way, and it looks at the WBC count, the leukocyte count. Okay, now this is what you have to do. You get lab results, right, for this patient. You run tests, you get back that their ESR, let's say, is 37. So that does not meet the criteria, so that doesn't count. You get back that their temperature is 102. That definitely meets the criteria of greater than about 101. It's really 101.2 or 3 or something, but it's around 101. So that does meet criteria, so we check. You realize that the child will not bear weight on that leg whatsoever. Won't stand on it, won't do nothing. So that meets the criteria for that. So won't bear weight on it, on the affected hip side. Won't bear weight, that meets the criteria. And the last one, they have a WBC count, let's just say of 14,000, so that meets the criteria. So after you've gone through these 4 things, is it ESR over 40? Is it a temperature over 101 or 101.2, somewhere in there? Is it, will the patient bear weight, and is the WBC count or leukocyte count greater than 12,000? Each point that you've checked yes to or said yes, it meets that criteria, equals 25% increased chance, about. So in this particular patient that we've just described down here, we looked at their lab results, patient X, they've meet 3 of the 4 criteria. So that means you give 25% for each of the criteria met. So they have a 75% chance around that they have septic hip over transient synovitis of the hip. Okay? That's an important distinguishing criteria to use, because say they don't meet any of these. If they don't meet any of these, they have around like a 0.02% chance that they actually have septic hip, and they probably have transient synovitis of the hip. If they're somewhat walking on the hip, so that means you don't meet this. If their temperature is 100, but it's not as high as 101, you don't meet that. We already said they're not born on the hip. If the ESR is like 35, but it's not as high, they don't meet that. If the WBC count is 10K, it's not greater than 12K, they don't meet that. They only have about what, scientists have proven, they only have about a 0.02% chance that they have septic hip, and then that means they probably have transient synovitis of the hip. So this is a really useful criteria to use. If you get a question and you have lab results where they give you all of this, you can use this if you're confused on which one of these two it would be. Okay? Very important, especially when you haven't done a tap into the hip yet, to look at the actual fluid and seeing, is there bacteria? Is there any sort of pathogens? And if you haven't done that yet and you're in the early clinical setting of just seeing the patient, this is a very useful criteria to use because you can get those lab results, blood testing back pretty fast. Okay, so that is the primary. That is the main childhood disorders of the hip that you would probably see on board exams, and I hope this helped you. It helped me a lot after I broke down a lot of this and used just the clever little mnemonics that we talked about. Just going back through this just to remind you the slipped capital femoral epiphysis. That helps me remember this is a chubbier kid. It's going to be probably a pubertal age, puberty, where you're growing a lot, so you're maybe be a little chubbier, so 10, 11, 12, 13. When you go back to here, Legg-Calvé-Perthes Disease, you use that leg to remember Lego, so this is a kid probably 5, 6, 7, 8, in that age range that usually gets this. And then the calve part just remembers calf. That helps me think of calf and thigh muscle atrophy. Developmental dysplasia of the hip, that was the first one we talked about. I look at developmental and I think that the group that is just starting to develop after being born is going to be babies, so this is usually caught or detected in babies. So those tips alone, if they give you an age of the child, which almost every question gives you the age of the child, that just alone you could probably get the answer just using that. But if that wasn't enough, then I've gone through a lot of the other characteristics to help you on these questions. Okay? So I hope this helped you. It really helped me a lot in understanding a lot of this. So if it helped you, like, share, subscribe, and